I was tasked with speaking about technical aspects in treating acute stroke in children. I have no disclosures. Any mention of a device in this talk is off-label because there are no on-label devices for use in children. And I want to start with the question of what does it mean to talk about a technical aspect in this procedure in terms of children. So for adults, it's fairly straightforward. Many of the topics that have come up already in this session, GA versus sedation, access, what's in your prep kit, what's your first-line device, second-line device, TPA, no TPA, things like that. I would argue that in children, actually, almost everything is a technical question. From establishing the diagnosis to prognosticating the likely natural history, choosing the appropriate imaging to use, and then plus all of the technical questions that come up in adults. And I want to illustrate that with a case. So this was a child, 6-year-old with Schoen's complex. Does anyone know what Schoen's complex is? I did not. Schoen's complex is this constellation of 4 entities, supravalvular mitral membrane, a morphologically parachute mitral valve, subaortic valvular stenosis, and aortic coarctation, very difficult to manage in the ICU. And this child had a mitral valve ballooning earlier that day and presented with a left MCA syndrome in the cardiac ICU. So here's the scan. You can see a left MCA cutoff, early DWI changes in the basal ganglia and hemisphere, lots of area on the perfusion scan at risk, and lots of dark vessels on the SWI, so it seemed like lots of brain at risk. And here's the angiogram, so you can see good cross-filling on the right side. There's a wedge of superior division missing on the left side. And we used a 3mm mind frame stentriever for this and got a very nice outcome with good flow. And imaging-wise, this was a terrific outcome. So here's the initial DWI on the left side and the final DWI on the right side. You can see it's a very good match, so there was no more brain infarcted. And the clinical outcome here was the child was left with a mild residual right hemiparesis, a hemidystonia, a mild expressive aphasia, so he's able to speak but with difficulty, and then attention and behavior dysregulation, which is something we very commonly see with acute stroke in children. So rage episodes and impulsivity. Now, I just want to point out that this was an in-house event at a tertiary pediatric medical center that has had a long-standing acute stroke protocol in place, and yet, with all that, there were still significant delays. So let's look at that. The time of onset was unclear, despite the fact that this happened in the ICU. The child got back from the mitral valve ballooning at 1:30, but was first noted to have decreased movement on the contralateral side and decreased responsiveness in the late afternoon. An hour and 40 minutes passed between the notification of the stroke team and the initiation of IVTPA with the imaging, getting all the consultations. Another hour and 30 minutes from the IVTPA to the groin stick, and then 11 minutes from the groin stick to MCA patency. So I would ask, what actually is the technical challenge in this case? It's not in doing the procedure, it's in all of the systems that lead up to that, and this is an in-house case. And of course, the reason for that is that cerebrovascular disease in children is very different from what it is in adults, and that's true both for ischemic disease and hemorrhagic disease. So in adults in Western countries, 80% of everything we call stroke is ischemic. In children, it's much closer to 50-50. In adults, the incidence of cerebral venous thrombosis is minuscule compared to ischemic stroke, whereas in children, it's 1/4 to 50% the incidence of ischemic stroke. In adults, the presence of aneurysmal subarachnoid hemorrhage is about 10 times the incidence of hemorrhage from a vascular malformation, and they're both dwarfed by hemorrhage from hypertension or amyloid, whereas in children, aneurysmal subarachnoid hemorrhage is actually quite rare. And then in terms of raw incidence, if you look at the WHO numbers, in adults overall for all ages, about 200 cases of stroke per 100,000, going up to about 500 per 100,000 as you get over age 55. In children, it's minuscule. It's 1 to 2 per 100,000. Outlier studies show 10 per 100,000, other than the population of children with sickle cell disease, where the incidence does approach the incidence in adults. And then the types of stroke that they have, even limiting yourself to ischemic stroke, is also quite different. And I'm not going to go through all these categories, but you can see really only embolic disease significantly overlaps with what you'll see in adults. That last thing on the list, the other, is a huge grab bag of possible entities that can cause ischemic stroke. So the bottom line is that the chance that the child rolling in with an acute neurologic change to your hospital is having a treatable ischemic stroke in a large vessel territory is actually minuscule. And so There are other technical challenges as well in terms of outcome. So I just wanted to show two cases that are not ischemic stroke, but they illustrate the point. This was a 22-month-old boy who presented with a seizure and then obtundation, had this intraparenchymal hemorrhage. You can see a small craniectomy at an outside hospital, but already ischemic changes in most of the hemisphere. You can see the cause here on the CTA. So this was an MCA branch dissecting aneurysm treated with a few drops of glue, no more hemorrhage. But of course, the outcome 1 year later, here's the MRA and here's the T2 weighted scan. You can see really loss of most of that left hemisphere. And yet, this child has very good strength in the contralateral arm with some increased tone. He has very good strength in the contralateral leg. He runs, he can stand on either foot, he attends regular nursery, communicates perfectly well. So the outcome is actually pretty similar to that Shone's case I showed you with a much, much smaller infarction. And here's another case just to show the example. A 3-month-old girl with a right MCA dissecting aneurysm had an operative mishap resulting in this DWI, and then 3 years later, here's her scan. And yet she uses the contralateral arm quite well. She does have limited use of the hand. She has no neglect, no sensory deficits. She's cognitively and socially completely intact. So it's extremely difficult to prognosticate the natural history in these cases, and sometimes it's much better than what you would imagine. This paper shows that this is true even in the posterior circulation. This came out of here, out of Toronto, showing that even for basilar artery strokes, the outcome in children is often far better than you would expect with that 99% mortality rate we talk about in adults. And interestingly, often when you hear adult neurointerventionalists talk about treating children, they'll show a case and they'll say something like, well, it was a child with a basilar occlusion, so I ignored the fact that 20 hours had passed or 50 hours had passed, and I went from the time of onset. And what you're doing is extrapolating the adult evolution onto the fact that this is a child, and that sort of raises the stakes. But it's not clear that that's the right thing to do. Does the child have more to gain or more to lose from that? We have to compare it to the natural history, which of course is very difficult to do. So what should the solution to that be? It should be we should do trials just as we've done in adults. And that is a huge challenge, unfortunately. So given the unknown response to lytics in children, the TIPS trial was organized a few years back. I'm sure many of you in this room are familiar with it, but it was a dose escalation trial of IV TPA. The original design had an IA arm, which was eliminated before the NIH approved it. And the goal was to just understand how to dose IV TPA in children. Interestingly, soon after the trial started, there was a paper published looking at just the greater Cincinnati area over successive 3-year periods. It was about a catchment area of 1.3 million people, and they did an analysis of potential children who could participate in this trial. And they found 29 cases with 3 eligible for TPA. And then extrapolating that up to the population of the United States, they thought there would be 178 potential eligible cases nationally. And for any of you who've been involved in a trial, you know that's not going to result in a real trial. And in fact, the TIPS trial was terminated for lack of patient accrual. So this is a huge problem. And really what we're left with is analyzing case reports and very small case series that have been published. So we did this twice, first back in 2012, and at that time we found 34 reported cases that were treated with IA techniques. Interestingly, in 11 of the 34, so about a third of them, mechanical thrombectomy was used, whereas in 2/3 IA thrombolysis was used. And 8 of the 34 cases had intracranial hemorrhage, most of it asymptomatic, but interestingly, mechanical thrombectomy was almost never used in those 8. One of the 8 did have mechanical thrombectomy, but it also had IA TPA given. So every case with an intracranial hemorrhage had IA TPA given. But of course, this is just a summary of very disparate treatment approaches and totally inconsistent workup and follow-up. It's just a collection of cases. We repeated this exercise last year in 2016, and we limited ourselves to modern interventions, so mechanical thrombectomy with relatively modern devices. We did go back to 2008, so we did include Mercy, but we excluded things like IA TPA, balloon angioplasty for acute stroke, maceration with a wire, and things like that. We found the average age of the patients was about 10. Most of them were M1 or basilar occlusions. And interestingly, the mean time from symptom onset to intervention was 8.8 hours. If you notice, the complete range was 1.5 to 120 hours. About 14% of the patients got IV TPA, and most of the patients got treated with a stent retriever or penumbra, with many of the early patients getting Mercy. The outcome was actually quite good. So flow was reestablished in a good level in over about 76% of the patients. There were no major adverse clinical events. There was one fractured Mercy device, and that was it, but even that had no clinical consequence. No cases of intracranial hemorrhage that was symptomatic. And the clinical outcome was excellent. So the mean, the modified Röntgen score at the longest available follow-up was less than 1. And about 87% of the patients had a good clinical outcome, with the caveat that there was not clinical outcome available in the whole cohort. So if you stop and think about that for a second, compared to adult cohorts, this pediatric cohort had comparably good clinical recanalization rates and very good clinical outcomes. And the thrombectomy was performed on average later than it would have been performed in the trials in adults. So that ratio, typically the recanalization rate in an adult trial is higher than the good clinical outcome rate, and that's inverted here in children. More of the children actually had a good clinical outcome even than the revascularization, and this suggests that there's an inherently intrinsic better natural history in children, and it's likely due to more robust collaterals. I would argue it's the mirror image of what we see in elderly patients, where the clinical outcome with the very same recanalization rate is going to be poor because the collaterals are poor. In children, you probably are working with much better collaterals. And again, I'll just add the caveat that only 23 of these cases had any clinical outcome reported, and if all of those 6 cases that were left out had bad clinical outcome, then the good clinical result would go down to about 69% rather than 87%. Okay, but just a few words about actual technical issues in doing these procedures in children. So one question that comes up a lot is, what about the size of the vessels, and are the devices made for adults usable in children? It turns out the answer is definitely yes, for the most part. So the growth of the head and neck structures in children is way out of proportion to the rest of the body. This is a classic paper from the plastic surgery literature from 1992, looking at CT measures of various elements of cranial anatomy. And you can see that already at a very young age, by age 1, most of the structures are at 80 to 90% of the adult size. That is certainly true for the upper face and the mid face. It's a little less true of the jaw and the lower face, but for the most part, you see that very, very early in life, you reach adult or close to adult size of structures. And if you look specifically at vessels, this has been shown several times now. So this was a paper from 2016, I think. Froller's group called this the rule of 5 because they found that in almost every vessel intracranially that they looked at, by age 5, the vessel had achieved pretty much adult size. And the only caveat to the paper is that their number in their cohort at the very young ages was quite small, but a similar result was published by this Turkish group a year or two before, and they had better representation of the very young ages. And it's sort of amazing if you look at it. In the 0 to 6 month category, the MCA basically at birth is 87% the size of an MCA of an adult. So really at a very young age, the intracranial vessels are at least of a caliber where they should be able to sustain the devices. However, that is definitely not true of your access, right? So of course, and we know that from looking at the legs of the child, the iliac artery grows much more slowly, and you can't count on adult type of access to do these procedures. And you certainly cannot just ignore the femoral access. So this was actually published by Pat Burrows just as she left Toronto Sick Kids. She did an analysis of iliofemoral complications in the cardiology group here. And you can see they were using 8 and 9 French systems in little babies. And there was an incredibly high rate of iliofemoral disruption, as you might expect. And you can see from the bar graphs, heavily weighted towards the very young children. And if you look at the chart here, you can see the weight, 5 kilograms, 7 kilograms with 8 and 9 French systems. That just as clearly does not work. So one does have to have an approach that is targeted towards age, mostly for access, not because of the intracranial issues. We do that, so we have an over age 5 protocol and an age 2 to 5 protocol. Most centers that I know that do any intracranial thrombectomy for children start at age 2. We've certainly never intervened at that young an age. However, with all of that being said, I just want to do a reality check. So I'm paged about every 3 or 4 months for a potential acute stroke intervention. And despite that, we have literally had 6 cases in which we did an intervention since 2012. And here's the list of them. You can see a 15-year-old, 8-year-old, 6-year-old. This was the Shone's complex patient, 14, 15, and 22-year-old patient. And so the net result of that combination is very unfavorable, right? It's a very, very rare event. that in order to manage appropriately requires incredible coordination of the team and extreme speed and efficiency. And if you look at our most recent case, I think it really highlights this. So this was a 15-year-old who was on contraceptive, but really no past medical history, became hemiparetic at 10 p.m., had an outside CT at midnight. Finally, someone thought to do a CTA at 1:30 a.m. and was found to have an MCA occlusion and M1 occlusion, was then med-flighted from New Hampshire, arrived to us at 3:45 a.m., then we actually re-imaged. Vitor mentioned this before in another case where enough time had passed that we wanted to see if anything had changed, so we did re-image. Then there was a little discussion with anesthesiology about not putting an A-line because we needed to proceed quickly, and then we finally had the groin stick at 5 a.m. And of course, I don't have to belabor this, but the session until now has spoke about this. These metrics in the adult world are all about efficiency, so it's door to CT time, door to needle time, door to vessel patency time. And centers are doing things like not using GA, which we just talked about. And realistically, things like that are really only possible for a procedure that you're doing repeatedly with the same team, and you can really hone down and get an efficient pathway in place. So there's just an intrinsic disparity between that kind of model and the reality of treating children with acute neurologic change. And I would argue, if you look at this case, so yes, there was an early delay between the onset of symptoms and that CTA, which maybe is unavoidable because it's a young patient and people don't think of stroke. But at 1:30 a.m., was that child actually well served by being med-flighted down to Boston for treatment? I actually would argue probably not. And I'm a big advocate of treating children at specialized centers, but in cases like this, I'm starting to have an ethical quandary about whether we're doing the right thing or not. So there are things you can try to do to mitigate this. These are some slides from one of our technologists who made a presentation for the other technologists, just as a refresher from time to time. What is in our kit? What devices do we have? What do you need? What are we trying to do? So these are just some things like that. But that's, of course, not an optimal way to address it. It doesn't address anybody outside the angio suite, and there are lots of systems issues in place. So I just wanted to end with some questions because I really think there are not conclusions here. The first one is, who should be treated? Should there be limits in terms of the pediatric stroke scale for admission to treatment like this? Should there be age limits? Is the time window for treatment expanded in children compared to adults? So one thing you might imagine is certainly it must be because the collaterals are better, but the flip side is maybe the natural history is better and we should not be intervening at longer time windows. I don't know. How can we possibly demonstrate efficacy, which I think we have to do compared to the natural history? Probably registries are the best thing we're ever going to have, but it's hard to imagine we could ever organize a real trial. A big question, I think, is where should these procedures take place? Adult centers, of course, are optimized for speed, and I would argue that most teenagers with a clear diagnosis, there's no diagnostic dilemma. If you get a CTA with an MCA cutoff, that patient probably is better served at an adult center. I think there are still questions then, like what happens to that child after treatment at the adult centers? Most ICUs will not admit a young teenager, for example, for observation there. On the flip side, very young children, any of us who is at a pediatric center has seen very young children treated by adult specialists with catastrophic results, so I think this probably only applies in the teenage years. And then are some thrombectomy techniques actually more suited to children's clots? We were talking about ADAPT versus Solumbra versus all different kinds of things. We have no idea what might work better or worse in children. And that's it. Thank you.